Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode includes content from an educational presentation from a dinner meeting titled Innovations in First-Line ART for Diverse Patients. This is part of a comprehensive program, Contemporary HIV Treatment and Prevention 2022. During this podcast, Dr. Princy Kumar from Georgetown University School of Medicine discusses ART selection in a newly diagnosed person with HIV. For more information about Dr. Kumar and this program, and to follow along with the slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Kumar has to say about this topic, starting with the case.
So let's start with the first case right here. This is a 57-year-old newly diagnosed male with HIV infection. He actually was on PrEP, but during the pandemic, discontinued PrEP. And that is a common phenomenon that we witness, that people just discontinue PrEP. He comes to you, and when he comes to you, his CD4 count is 340, his viral load is 67,000, his hepatitis B immune, and I'm going to say HLA-B5701 status positive. The BMI is only 21. That's good. They did a resistance testing and they said no resistance-associated mutation. The LFTs are normal. All his labs are normal. And he comes to you and said, I just want a single tablet regimen. I see advertisements in the night every day, and I want a single tablet regimen. So here I'm going to tell you, these are the DA. So here, if you look at it, I'm going to show you two different things. These are recommended first-line ARV regimens for most people living with HIV infection. There are always exceptions. Here is our Department of Health and Human Services guidelines right here. And this is the IAS, that is the International AIDS Society USA guidelines. They're very similar in most ways. And if you look over here, all of these, this is only listed in alphabetical order. That's what it is. It's not the one that you can choose any one of this regimen and you're within the guidelines. So the first is bictegravir FTC TAF. The second is dolutegravir 3TC abacavir if the HLA-B5701 is negative and they don't have chronic hepatitis B. C is dolutegravir if you don't want to use an abacavir-based regimen, and many of us are going away from an abacavir-based regimen, then you use dolutegravir with either TDF or TAF with 3TC or FTC. And if you look at, let's take a minute and look at the difference between TAF and TDF, okay? So I know some of you are, during the COVID pandemic, didn't spend a lot of time with HIV. So let me take a minute and go through the difference between TAF and TDF. Both of them are prodrugs, TAF and TDF. So I'm going to tell you what it is. So the first drug that was there for the years and years and years was TDF. So TDF, so it's tenofovir diphosphorfumarate. And the dosage of that, if you look at it, is 300 milligrams. So, but it had two important side effects. It caused renal toxicity, including Fanconi syndrome. Fanconi syndrome means you can waste things through the renal tubules, and it caused decrease in the bone mineral density. So over a period of time, the company that had TDF then developed a different type of tenofovir. It's still tenofovir, but it's called tenofovir alafenamide, and it's a drug that has greater bioavailability and better ability to penetrate into the cell. So the dosage, it's both of them are tenofovir, but TAF has only 25 milligrams of tenofovir, whereas TDF has 300 milligrams. So it's a lower dose, but achieves the same level. So the sense is that it has less renal toxicity and less bone mineral toxicity, but it is also, I will tell you upfront, we believe that it has greater potential to cause weight gain. Okay, so nothing is completely good. There's always some downsides associated with that. So in the earlier guidelines, if you look over here, the IAS, UAS guidelines only had TAF. They did not have TDF. If you looked at the previous year, the 2 years, they come up every 2 years, they only had TAF, but but because of the more weight gain associated with TAF, they revised their guidelines and added TDF back to them. Okay? And last but not the least, if you look at any one of these regimens, it's always a 3-drug regimen, right? For HIV infection, the way we treat is where one anchor drug, which is either an integrase inhibitor or a boosted protease inhibitor or an NNRTI. The preferred drug is always an integrase inhibitor, and then you add 2 NRTIs to that. So it's always a 3-drug regimen. But if you look here, for the first time, they added a 2-drug regimen of dolutegravir and 3TC. That's a 2-drug regimen. So it is only recently that a 2-drug regimen was added, but there are caveats to whom you can give this 2-drug regimen. It's within the guidelines. I use a 2-drug regimen, but the people that you should not use a 2-drug regimen are people who come in to see you for the first time and they have a very high viral load of greater than 500,000, or if you don't have their resistance profile when they come to you, it's too risky a chance to take, or if they're hepatitis B positive. Then I wouldn't use a dolutegravir. I actually don't use it upfront. I always start them on some other regimen, and then later on I convert them into a 2-drug. And people will ask, but why are you changing them to a 2-drug regimen with the gold standard? It's because treatment for HIV, we now know, is lifelong treatment. We are working towards a cure. I do believe from the bottom of my heart, we will get to the cure. There are lots of people working on it, lot of good patients volunteering to it, but we are not there now. So till we get to a cure, why not give the least amount of drugs that can keep them suppressed? That's why it's the 2-drug regimen is so important. So that's where it is. And if you look here, I'll pass over. I'll just say, so overall, if you look here, if you look at this regimen, all of the anchor drug is all an integrase inhibitor. Bictegravir is an integrase inhibitor. Dolutegravir is an integrase inhibitor. So the anchor drug is now an integrase inhibitor. And so the question is, among the integrase inhibitors, are there any differences? We don't use elbetagavir anymore. That's been taken off of the guidelines. And if you look over here, in my mind, there's really no big differences between all that. They're all the same. Reltagavir we have the longest, it's no more among the preferred regimens. The time that we use reltagavir, I use it, I only use it when I'm in pregnancy or people who are treating for TB, because it's just a least drug-to-drug interaction. Okay? So there's also a huge emphasis right now to rapid ART treatment. What rapid ART treatment means, if you see somebody with a new diagnosis of HIV, most of us will get all their labs, we talk to them, we get all their labs, we get their genotype tests done, and we tell them, I'll see you. Like if I see them today, I'll say, I'll see you from a week from now, come back, all your blood work is back, I'll start you on treatment. Rapid ART treatment is on the day that you see them, you just send all their blood work and start them immediately on ART treatment. Now there are pros and cons for that, okay? So I'm only going to tell you, for rapid ARV treatment, the drugs that you can use are either, you don't use the dolutegravir 3TC, first to say. You can either use bictegravir FTC TAF, dolutegravir TAF, and or boosted durinavir. Those are the rapid ART. I don't do a lot of rapid ART. I think waiting for a week, nothing is fine. Okay? So you're going to ask me, if integrase inhibitors are the golden children right now, everybody wants it. Is there any data on alternate drugs? And I'm going to say yes. There are reasons in which we can use other agents for. And the first agent I'm going to tell you is about a boosted PI. So this is durinavir with cobicistat, FTC and TAF. This is now available in a single tablet regimen. It's available as a single tablet regimen, durinavir, cobicistat, FTC and TAF. So where did the data come from? So if you look at it, they compared that to boosted durinavir. So cobicistat was used instead of ritonavir, and they compared the two. And if you look at it, overall, both regimens did equally well. And this is the AMBER trial in which durinavir, cobicistat, FTC and TAF did as well as the split-up regimen. But the point I want to make to you is that I still use a protease inhibitor, not for all of my patients. I still use it for two reasons. One is I think it has a very high genetic barrier to resistance. So if I think I'm not sure about the compliance of the patient, I'm not sure how regularly they're going to take the drug, I go with a boosted PI. Now, both dolutegravir and bictegravir also have high genetic barrier to resistance, but nobody has the genetic barrier as a boosted PI. And even if you fail a boosted PI, you don't develop resistance to the boosted PI. So that's when it really has a very high genetic barrier to resistance. It really saves the companion drugs. So they are few and far between. Most of the time, we just give an integrase inhibitor and they do very, very well. Now, there's a second drug that has come into the market. I use it quite a lot. It's an NNRTI called doravirine. Remember, that was the first combination that came out with efavirenz. What is the problem with efavirenz? The most important side effect of efavirenz, it was a very effective drug, was its CNS side effects. People got depressed. People had suicidal ideation. People felt like it made them feel foggy. Okay? So that is why it fell in disfavor. But we have always thought, and it had a low genetic barrier to resistance. So there was always a feeling that NNRTIs, there is hope in the other things. And so a drug called doravirine was developed, and I used quite a lot of doravirine, and there were a number of clinical trials using doravirine. There was a clinical trial comparing doravirine, PTC and TDF as a fixed dose combination versus efavirenz, FTC, TDF, because they are both NNRTIs. And there was a second trial comparing doravirine with any two NRTIs that the physician wanted, comparing it to boosted durinavir. And in both studies, drive ahead and drive forward, doravirine, where efficacy was concerned, did very well. It really was comparable. It was even comparable to boosted durinavir, which at that time we thought was a gold standard. So, the one thing, if you look at it, it has less CNS side effects than efavirenz, and its lipid profile was better than boosted durinavir. So it's a very good drug, but right now it's not part of the DHHS guidelines for first-line regimen. I think things will change. Where I use it a lot, I don't use it when I see patients for the first time. That's not what I use it. I tend to use it after I put them on a drug, they suppress. Now, remember I told you about the 2-drug regimen of dolutegravir and TTC. Where did all the data come from? How did the FDA approve it? How did it get into the DHHS guidelines? 2 very important studies were done. One was called the GEMINI study and one was called the TANGO study. I'm simply going to show you the GEMINI study. In the GEMINI study, they took dolutegravir with FTC TDF. Okay, so they compared dolutegravir with FTC TDF versus dolutegravir with 3TC alone. Okay, these were patients who were these were newly diagnosed patients, positive with a viral, but if you looked at it, they had to have a viral load less than 500,000. They didn't have any resistance. They were antiretroviral line. They came in, they got randomized to get either dolutegravir 3TC or dolutegravir FTC TDF. At 48 weeks, 96 weeks, 144 weeks, dolutegravir 3TC, a 2-drug regimen, was comparable to dolutegravir FTC TDF. This is really where the data came from. This was one of the reasons why they got the FDA approval. There was a second study as well. Now I'm going to show you the subgroup analysis at 104, because we always say 48 weeks is not enough, 96 weeks may be okay, but at 144 weeks, we feel more comfortable that durability of the regimen, that it's a durable regimen. Here, the analysis was done on whether if you're older, if you're male or female based on race, no difference. But I, as a clinician, I don't look at any of that. I don't think there's any difference whether you're black or white. I think you're going to do the same. I personally think. But what I, as a clinician, do is I look at what did you do if you came in with a high viral load. To me, that is the litmus test. Did you do equally well if you came in with a high viral load, or did you fail when you came in with a high viral? And then I look at the CD4 count. So here, whether they came with a viral load greater than 100,000, 82% of patients became undetectable, compared to 84% with the dolutegravir FTC. So really no difference. So that's the first thing I do. When anybody presents me the data, I say, show me. Forget about all of this. That doesn't matter to me. Show me the data for people with viral loads. The next thing I say, show me the data for people with CD4 count, low CD4 count. Because we know when you have a low CD4 count, the barrier is higher. And here, with a CD4 count greater than 200, they actually did very well. But CD4 counts less than 200, there was actually dolutegravir 3TC did less well than the 3-drug regimen. So even though the FDA didn't put that as one of the contraindications, most clinicians will not use it with people with low CD4 count. Okay? So I want to start off and just telling you. Now, who can tell me? So right now, the integrase inhibitors are the first-line regimen. That's PDED. I'll tell you some of the drawbacks of integrase inhibitors, but the reason that protease inhibitors, though they have a very high genetic barrier to resistance, are not the preferred drug for first-line regimen is really because of the fact they really have more GI intolerance because they always have to be boosted. You can't give it by itself. You have to give it with either ritonavir or cobicistat, and both of them have GI side effects. And the other big thing is hyperlipidemia. They are much more likely to have rises in your total cholesterol, rises in your LDL, and because of that, the concern is cardiovascular risk factor. They also are more likely to cause insulin resistance. This is the reason why the protease inhibitors are not your preferred regimen. This is the reason why integrase inhibitors are the preferred regimen. Okay? Let's look at the NNRTIs. the reason NNRTIs are again not the preferred regimens is really the single most important reason is a lower genetic barrier to resistance and the neuropsychiatric side effects. Doravirine actually overcomes some of this. It doesn't have the same amount of less neuropsychiatric disturbances. Its genetic barrier to resistance, in my experience, is a little better. So we're waiting to have more data come out so the DHHS can add it to the first line regimen. So now I'll talk about the difference between TDF and TAF. Remember, I told you what TDF was TAF was. So if you look at the TDF is the one that we all grew up using. TDF is the one combined with FTC. TAF is what is combined again with FTC. Earlier on, we said when TAF with FTC came out, we all said if you have less nephrotoxicity, if you have less ability to cause bone marrow density, we want less impact, we want to be able to use TAF. However, now we clearly know that there's much more weight gain with TAF than with TDF, abacavir, or any other drug. So that's the one drawback now that we see with TAF, is the weight gain that people are experiencing. Okay? So here are my take-home points. So the initial preferred regimen in the US right now, is an integrase inhibitor. It's not a PI, it's not an NNRTI. And then both you can use either dolutegravir or bictegravir, both have high barriers to resistance. And then FTC TAF has improved safety and tolerability, but it appears to be associated with more weight gain. And then I want to tell you that right now, dolutegravir and 3TC as a 2-drug regimen is now in the DHHS guidelines as a preferred regimen for initial treatment of ART. With the caveats, what did I tell you are the caveats for dolutegravir and 3TC? We as clinicians, its viral loads greater than 500,000 because it was not studied in the GEMINI. And if you have underlying hepatitis B, those are the two big things, or you don't have your resistance profile. But as clinicians, we then added the CD4 count because we saw it.
Thank you very much to Dr. Kumar, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2022 program on the Clinical Care Options website, and to access the slide set for innovations in first-line ART for diverse patients, click on the links in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you.